Hi, I'm Mandy Nuccio, and I'm going to do a quick review of PAP titration protocols and what we can do to maximize our chances to have a successful PAP titration with our patients. CPAP needs to be titrated to find the patient's lowest setting. It is an optimized trade-off to increase the pressure enough to eliminate respiratory events while also trying to avoid any pressure-related side effects. It can be a delicate balance. The ASM standards for how to perform a titration state that CPAP should be increased by at least 1 centimeter of water pressure by no more than 2.5 centimeters of water pressure, waiting at least 5 minutes between each pressure change. Now, generally, we don't increase in half increments, so really what this means is we're increasing in increments of 1 or 2 centimeters of water pressure at a time, waiting at least 5 minutes between each pressure change. As CPAP is increased, you'll typically see that apneas are eliminated first during the titration, hypopneas following, then RERAs, and eventually snoring. Not always the case, but oftentimes you'll typically see it go that way. Ideally, what you want to find is the PAP pressure that is selected for the patient should eliminate their respiratory events, keep their oxygen in a healthy range, and their mask leak should be within acceptable parameters so that we know that the pressure that the patient is on is treating their apnea and not compensating for a poor mask fit. The ASM published when the CPAP should be increased, and that's when 2 or more obstructive apneas are observed, 3 or more hypopneas, 5 or more RERAs, or 3 minutes or more of loud indefinite snoring. Now, typically, that's the minimum that we should see in order to increase CPAP. This is the minimum set forth by the ASM for when CPAP should be increased. However, I want to make note that recording by the minimum standards shouldn't give pride and doesn't necessarily ensure a satisfactory test. Sometimes the minimum standards set forth for us as technicians provide barely adequate fulfillment of our responsibilities to not only the patient, but also to the referring physician. So what can we do to improve? First and foremost, slow down. We've got all night. While the ASM allows increasing CPAP pressure in increments of 2 centimeters of water pressure, generally that is a pretty aggressive technique if you're doing it in the treatment of snoring, RERAs, that type of thing, or especially when you get to the higher pressures. When possible, slow down and go in increments of 1 centimeter of water pressure. I really only aggressively titrate and go up by 2 when the patient's having back-to-back obstructive apneas because I really just want to break their airway open for them. And once that's open, then I can slow it down. The other thing is the ASM requires at least 5 minutes at the pressure. Ideally, we want to give the patient more time on each pressure so that they have time to adjust to the pressure. It'll also give the physician an adequate little sample of how the patient did at that particular pressure. The other thing we want to do is observe our patient, look back and review their progress. If we've had them at the same pressure for quite a while, what can we do? Can we maybe increase it a little bit more to show a little bit of exploration and to show a range? Or should we possibly start considering maybe doing a down titration to see how the patient will tolerate as we lower the pressure back down? Ideally, the titration at the end of the night, we've got the patient treated. They are tolerating treatment, they're comfortable, and they're on the lowest possible pressure that gets their apneas completely eliminated. Their oxygenation is in an adequate, healthy range. Their arousal index is less than 5, so it's at a normal level, and ideally their snoring is also eliminated. The ASM does allow for us to do CPAP exploration, which means that once we find what we think is the optimal pressure for the patient, that we can then go a little bit beyond that to just somewhat show a range, so to speak, or explore. Oftentimes, we might not have obvious overt respiratory events happening, but you might find that your patient is still waking up fairly often, having some airflow limitation, and in that regard, CPAP exploration would be a great option to try because as sensitive as all of the items that we put on the patient for a diagnostic polysomnography test, it might not be enough to pick up what could be still happening. Upper airway resistance could still be limited despite not having any obvious respiratory events going on with the patient. And so by increasing the pressure slightly above what we might have thought originally to be best for the patient, it could actually improve the patient's parameters. It could improve their arousal index at higher pressures and just their overall consolidation of sleep. When doing CPAP exploration, you want to increase the pressure maybe one or two higher than what you felt the optimal pressure was, but don't go higher than 5 centimeters of water pressure above what you felt optimal pressure was. So for instance, say you're doing a titration, you felt the patient did best at a CPAP of 10, well, you can show a range by slowly going from 10 to 11 to 12, even up to 13 and 14, but don't go any higher than 5 above what you felt optimal pressure was. ASM also recommends trialing a down titration. That can be an option when after you've done a little exploring with the pressure to go back down on the pressure. So after 30 minutes, if you've had a study running for more than 30 minutes and there hasn't been any obstructive respiratory events, then you can start trying to decrease and slowly decreasing the pressure back down. You're going in increments of 1 centimeter of water pressure until respiratory events reemerge. Typically, because of hysteresis phenomenon, you'll see that during a downward titration where respiratory events reemerge, that pressure is actually lower than what you need, the pressure that was required to eliminate the respiratory events during an upward titration. The ASM defines an optimal titration by having the patient at a PAP pressure that reduces their RDI to less than 5 for at least 15 minutes, and that includes REM supine sleep. A good titration is considered an RDI of less than 10 or by at least 50% of the baseline RDI, and that also includes REM supine sleep. You might see a good titration in patients that are quite severe. If their starting baseline RDI is very, very high, sometimes we're not always going to necessarily get them to less than 5, but a significant improvement over what they originally came in with without PAP is still something that's considered pretty good. An adequate titration doesn't reduce the RDI to less than 10, but it does reduce it by 75% from the baseline. Or a titration would be considered adequate if we were able to reduce the RDI to less than 5 or less than 10, but we weren't able to record REM supine sleep. An unacceptable titration means that we weren't able to reduce the RDI to less than 10, and that we did not get at least 3 hours of a titration duration during a split night study. Typically, if a titration is considered unacceptable, the titration might need to be repeated. When to switch to BiPAP. You'll make the jump from CPAP to BiPAP when CPAP is maxed out. Some labs have protocols that require that you make the jump from CPAP to BiPAP at a specific PAP pressure, such as once a patient reaches a CPAP pressure of 15, instead of going higher than that, you're going to switch them to BiPAP. If the patient doesn't tolerate CPAP, of course, try to explore why the patient might be uncomfortable or intolerant of CPAP. See if we can do something to help them tolerate it a little bit better. If not, make the jump to BiPAP. If they're hypoxemic despite having elimination of all of their respiratory events, we can make the jump to BiPAP to see if we can't eke their SpO2 out of the hypoxemic range without having to add in supplemental oxygen. Sometimes augmenting the tidal volume by increasing the IPAP is enough to get the patient's saturation into a healthy range without the requirement of adding in supplemental oxygen. patients that have neuromuscular or hypoventilation disorders, if you're having significant mouth leaks or aerophagia, air swallowing, another indication to potentially switch to BiPAP. When making the jump, the initial starting settings can be based on what you're going off of with your titration. If you're doing a straight BiPAP titration, the initial starting setting is 8/4. If you're making the jump from CPAP to BiPAP, your minimum starting EPAP should be at least 4. Or what you can do is set your EPAP at the CPAP level where obstructive apneas were eliminated, and then set IPAP 4 above that. If you are switching over to BiPAP because the patient can't tolerate the high pressure or because you've maxed out your CPAP, what you're going to want to do is set your IPAP at your current CPAP setting and then set your EPAP 4 below that. Your starting IPAP EPAP split is usually around 4, and then as you begin to titrate PAP, you can deviate from that. So you're going to maintain a minimum split of 4 between IPAP, EPAP, maximum split of 10. You're going to increase both pressures in a stepwise fashion until you eliminate the apneas. Once obstructive apneas are eliminated, then EPAP is going to stay planted where it's at, and you're going to only increase IPAP for the rest of the respiratory events that you see: apneas, hypopneas, RERAs. Optimal IPAP really is achieved once all the arousals, hypopneas, and desaturations have been eliminated. Optimal EPAP is achieved when the apneas have been eliminated. We can still do IPAP exploration just like with CPAP. Once you've got the patient titrated, go a little bit beyond where you are to see if maybe it does improve other parameters such as sleep fragmentation, anything like that. You can also consider a down titration. So if you've had the patient at the pressure and for quite a while and they haven't had any obstructive respiratory events, you can see if maybe dropping the pressure back down will do some good for the patient. So this is all well and good. We know how it goes by standards, what we're supposed to do. But here's how it looks in real life. And in real life, it's not always as simple. So I found going from night tech to score tech, it helped to see what the physicians are looking at in order to make that decision to find what the optimal pressure is for the patient. And so in this example, we can see that the patient was trialed on CPAP of 4 through 8. They spent quite a lot of time on a CPAP of 7 and 8, and they spent that time sleeping. They got some REM on pressures 6, 7, and 8. But when we come down here, we can see that their RDI was never completely fixed. And in the tech notes, it stated that the they recorded that the patient's optimal pressure was 8 and that no remarkable events occurred at CPAP 7 or 8. But we can see that events did occur. And so this patient wasn't fully titrated, and instead their optimal pressure was not found because there was a lot of time just left at these pressures when the tech should have been going a little bit higher. In this example, the patient was titrated on a CPAP of 5 through 13. Again, if we come shoot over here, we see that their RDI is still really high, pretty much throughout. We see it lowest here on a CPAP of 9. In the tech notes, the tech stated that the patient's optimal pressure was at 12. What you can see though is that as the pressures kept increasing from 9 and up, central apneas really started happening. And the tech did recognize the central apneas because when they made the jump from 12 to 13, the patient was only left at this pressure for a little over 6 minutes before they dropped them back down to 12 due to emergent centrals. That's what they wrote in their documentation. But what was missed is the number of central apneas that started happening far before that. That means that the pressure really shouldn't have gone as probably as high as it did, because at this point they really were knocking the drive out to breathe. Or if there still was this increase in the centrals and you also have more of these obstructive hypopneas, maybe considering a switch over to BiPAP might have been a more efficient use of trying to find that magic pressure to get this patient treated. In this example, we have a patient was trialed on CPAP 7 through 17. In the text notes, they stated that the patient, their optimal pressure was at 17. Now remember, just because it's your ending pressure, it doesn't necessarily mean that it's your optimal pressure. Yes, the patient's RDI was only 3.3 at this pressure, but what we also have to look at is the number of central apneas that started happening. So at CPAP of 15, technically the patient was treated. 1 or 2 events, an RDI of 3.9, completely acceptable. As the tech kept increasing the pressure, though, the number of central apneas increased, which means that they knocked the drive to breathe from this patient. They were over titrating. The tech documented and observed the central apneas. It's not that these events were missed, but they still continued to increase the pressure above that. And in the documentation, their reasoning was for DSATs. In this example, the patient was trialed on CPAP 4 through 9, except 7 was missed. They went right from 6 to 8. The tech stated in their notes that the patient's optimal pressure was at a CPAP of 9, and you can see their RDI was 0 here. But the other thing that is not included in these reports is what's the patient's arousal index at each of these pressures. And when I looked at why the tech jumped from a CPAP of 6 to 8, they increased from 6 to 8 because of hypopneas with DSATs, or just a single hypopnea with DSAT. So that was a pretty aggressive jump to make for a single hypopnea with a desaturation. They only left the patient on a CPAP of 8 for 14 minutes before they increased them from 8 to 9 for comparison. So again, this is where you really, if you think that this might be an optimal pressure, the patient did really well at a CPAP of 8, leaving them there for a little bit more time to really see how they do at that pressure to give a really good sample on how the patient does at that particular pressure. The score tech observed that while looking at just the numbers, RDI wise, CPAP of 9 is better than CPAP of 8. When looking at the raw data, there's a lot more sleep fragmentation, a lot more spontaneous arousals that was happening at a pressure of 9, and that the patient actually did better on a CPAP of 8, but there just was a very limited little picture of how the patient did at that pressure. Patient was left at CPAP of 6 for almost 4 hours. Why couldn't we have had more time at a pressure of 7 and 8 and 9, just to really give a good example of how the patient did? Skipping CPAP of 7 feels like a missed opportunity. Could that have been the patient's optimal pressure? We don't really know because we didn't even get to see it in this titration. In this example, the patient was trialed on a CPAP of 4 through 11 and then switched over to BiPAP 11 over 7 to 15 over 8. In the text notes, they stated that the patient's optimal pressure was 15 over 8. And again, just because it's your ending pressure doesn't necessarily mean that it's your optimal pressure. And that the tech switched the patient from CPAP to BiPAP because of persistent central events. As you can see from the numbers, their RDI was pretty high up until the patient reached a CPAP 11. They didn't sleep at all on a CPAP 11. Yeah, they had a few central events as well, not a huge amount. Making the jump over, the patient's RDI did seem to improve as they were on BiPAP. And actually, their probably best pressure was 12 over 7 because as the pressure continued to increase, the central events continued to increase. So this patient was actually over titrated at 15 over 8 because their drive to breathe was knocked out. Here's an example of a patient that was really severe starting off. So the technician was pretty aggressive with increasing the CPAP, going from 4 to 6 to 8, all the way up to 20, and rightfully so, because the patient was still very severe. At 20, the CPAP maxed out, so the tech switched them over to 22 over 18 and continued to aggressively titrate. But as you can see, they aggressively titrated, and in the beginning, this absolutely was warranted because the patient had a lot of obstructive apneas, back-to-back events, resulting in very high RDI. But as you get to these super high double digits, that's when you really want to slow down. They went from 28 over 24 to 30 over 25 and then left the patient there for 4 hours. Ultimately, the patient probably did best at 28 over 24. But once the patient got up to here, it would have been nice to see, having left him there for about a half hour, and then backed him back down, do a down titration, 29 over 20 or 29 over 25, um, 28 over 24. Keep slowly backing it back down and go back to the pressures that were skipped potentially. Because again, those could all be missed opportunities. Maybe the pressure, maybe we missed the patient's optimal pressure because that optimal pressure was skipped. It's easy to look at these charts and Monday morning quarterback it all day long. Hindsight is 2020. So I'm not critiquing necessarily the tech's decisions at that particular time, because they're the ones that are, you guys are the ones that are running the studies that need to make these snap judgments. But sometimes by seeing these examples, it can help you kind of and guide you to make certain decisions as you're running the studies as well. Slow down. You can always do a down titration as well. Your ending pressure isn't necessarily the optimal pressure, and pay attention. Make sure that the patient truly is treated and what type of events are happening. Make sure you don't knock your patient's drive to breathe out.